Welcome to Soft Tissue Management Treatment Planning. Let's get right into it. First things first, we all need to know some easy insurance codes so we're all speaking the same language. 0180 is a complete periodontal evaluation. 1110 is a prophy. 1330 is oral hygiene instructions. 4346 is gingivitis therapy. 1110P, initial periotherapy or IPT appointment. The P is for perio and your own records and does not affect insurance submissions. We're going to talk about this more later. 1206 and 1208 are topical fluoride varnishes. 4342 is scaling and root planing for 1 to 3 teeth in the same quad. 4341 is scaling and root planing for 4 or more teeth in the same quad. 4910, perio maintenance, or what I call supportive periodontal treatment. 4381 is local delivery of chemotherapeutic agents. I use this for a Reston placement. 4999, unspecified periodontal procedure by report, is most often used if you're using a laser in your practice for periodontal treatment. Now, I like to use some acronyms that call the appointments what they are. I've alluded to some so far already. A regular prophy would be preventative care therapy, or PCT, in 1110 code. If a patient has gingivitis, I refer to it as preventative periodontal therapy because you're preventing them from going into perio. So PPT, or 4346 code, because we're treating the infection from continuing into perio. The first appointment is where perio is diagnosed, or the IPT, initial periodontal therapy, and it could be an 1110P or 4355. I'll explain the difference. The second and third appointments are usually active periodontal therapy, or APT, often 4341 or 4342 for scaling and root planing. The last appointment before a 3-month, 4-month recall is supportive periodontal therapy, SPT code 4910, or periodontal maintenance. CPT stands for chemotherapeutic periodontal therapy, like a Reston 4381. Okay, let's talk about the first appointment for a generalized perio patient. In the data gathering, we do the health history, intraoral photos, radiographs, and we explain that perio charting is next with a small blunt ruler, and anything greater than 3 is inflammation and bleeding, and that means active infection. Now, case presentation begins to intertwine with treatment planning, and to review, our first step in case presentation is to probe out loud. Don't forget to do that. Now, boom, the patient has infection. Let's say generalized perio for now. Step 2 in case presentation is sit the patient up and to go eye to eye and knee to knee, remember, and have the conversation. From the numbers, you can tell the bad news is your gum tissue is not healthy, and the good news is we are experts in helping you get healthy again. Step 3, I'm gonna have you watch this 3-minute video to understand what's going on a little better, and then step 4, classify the patient, enter the notes, and put the treatment plan in the computer for upcoming financial arrangements. After the perio video, follow step 5 in case presentation and explain we have to do 3 things differently, remember? We need to do more than a regular cleaning. We need to have you change what you're doing at home because what you're doing isn't working, and we need to see you more often. You would now take time to evaluate what they're currently using at home and make sure they change it to a power brush and better mouthwash. This all might take up to 30 to 40 minutes. Don't skip on any of it. You will not have time to clean their whole mouth anyway. So just do the tip of the iceberg for a cleaning and tell them that. Use the tooth iceberg photo I have in my free downloads. Help them visualize that today you're doing above the water or above the gum line, and that you've just started treatment and it's not finished. You have a lot of work to do. Do not polish, floss, or fluoride in this appointment. The patient will think they're done. I've got to admit, I myself as a hygienist have been known to clean the lingual number 24 and leave 25 rough and dirty so that they can feel there's more to do. Then do the exam the last 10 to 15 minutes of the appointment. Next, what do you charge out and what do you code for this IPT appointment? A few things to keep in mind. The patient came in expecting a regular cleaning with no follow-up cleaning appointments and no out-of-pocket expense for the cleaning today. According to the CDT, the definition of a prophy is the removal of plaque, calculus, and stains from the tooth structures in the permanent and transitional dentition. It is intended to control local irritational factors. So even if you only do the tip of the iceberg cleaning, you could call it an 1110. One of the reasons I wouldn't do an 1110 is if you have an insurance company that will not pay for SRP after an 1110 for a long period of time. If that's the case, I would charge out a 4355. The CDT says that a 4355 is the removal of subgingival or supragingival plaque and calculus. The procedure does not preclude the need for additional procedures. You might have no choice but to code the appointment of 4355 if you can't probe accurately incorrectly because of too much calculus. Yes, with a $43.55, there could be an out-of-pocket fee, and often it is only paid for once in a lifetime. But don't let that scare you. When I talk about presenting financial arrangements, you will see how to address this. No matter what, be insurance aware, but not insurance driven. The goals of this first appointment would be help the patient understand and own their disease, improve home care, jumpstart the healing process, reduce inflammation and bleeding so that the patient will not be so sensitive. So the need for local anesthesia at the next appointment is reduced. There's no bigger time vampire that sucks valuable appointment time away than waiting for anesthetic to work on tissue that is infected. Now, in no way am I saying hurt the patient, but let's not make general anesthetic an automatic in treatment planning. A supragingival full mouth debridement in 10 or 15 minutes removes the supragingival deposit and initiates healing when completed prior to periodontal scaling and root planing. Local anesthetic is needed only 5 to 10% of the time with patients that get a tip of the iceberg cleaning. According to the Journal of Clinical Periodontology in 2005, 45% of patients were more willing to return if they received treatment without local anesthetic. There's one objection to this that I have heard occasionally, and I hate to even talk about the exception rather than the rule. I like to focus on the rule. There's always little teeny exceptions that might happen, and it's not wise or effective to focus on those, but I will mention one here. Some people have worried about perioendo abscesses by doing a supragingival cleaning on the IPT appointment. It is a very, very, very minimal occurrence, if at all. In all the clients that I have taught this to, not one has come up with a perioendo abscess. I know there are hygienists out there that have. I just want to make the point, the vast majority of the time, it's not a problem. So let's not focus on it, and let's do what's best for the patient and most effective for the practice and the practitioner. After the exam, the hygienist would hand the patient off to the treatment coordinator for financial arrangements. As the hygienist, I put a full treatment plan into the computer with all the appointments needed for the next 3 months, plus any mouthwash or power brush or any antimicrobial agents or laser therapy that could need to be done. The treatment coordinator should present the entire fee for 3 months. Think of it like going to the oncologist for cancer treatment. They will tell you everything you need to do to get better in a certain time frame. Do this the same way, and don't let the patient line item veto any procedure or appointments. Most patients won't when it's presented in a 3-month time period. If they do question any items, let them know the risks of not doing that item. If they had no objections to the treatment with the hygienist and the dentist, but then get to the treatment coordinator and object because of money, just like any other objection to any other procedure, use the words feel, felt, found, and help them want treatment, and help by giving them options to find a way to pay for it. Now remember, we're talking about the generalized perio patient. I would code this first appointment in 1110p so that there is no out-of-pocket expense for the patient for this appointment. Again, there are 2 exceptions. If I can't probe accurately, or 2, the patient's insurance won't allow for an SRP or 4341 soon after. This means the hygiene team and the admin team need to know which insurance plans you take and if this is the case with any of them. If this sounds too complicated, you can brainstorm as a team. Which code would you want to stick with? Either way, it doesn't matter which one you use because you're presenting the 3-month total fee for all appointments and supplies anyway. So adjust your total and your insurance estimates accordingly. What do the 3 months of STM appointments look like? We just described the first appointment. The next appointment should be based on full mouth disinfection for several reasons and several benefits. According to Dr. C. Hamaker and Dr. J. M. Stein, goals for full mouth disinfection are to rid all subgingival areas of periodontal pathogens, which avoids reinfection from one untreated site that should be expected when quadrants are treated several weeks apart. So obviously, you're gonna clean one, there's what's to keep that from getting reinfected? Nothing. You clean one quadrant, the patient goes home, during the next week, that's not gonna stay sterile. We now know that there's also a positive effect on the general state of health. The risk of suffering a heart attack or stroke as a result of periodontitis can be reduced through systematic and lasting treatment of periodontitis. Another known advantage of intensive periodontal treatment in the form of full mouth disinfection is that after full mouth disinfection, the elasticity of the blood vessels improves significantly. So this concept achieves a much greater reduction of the risk of atherosclerosis than conventional therapy. Quote, one visit of full mouth scaling and root planing has been found to be clinically as effective as 4 one-quadrant visits, according to the Journal of Clinical Periodontology. Fewer appointments to me is a win-win-win. And after watching class 6.8, you know how important it is is to be effective and efficient. Full mouth disinfection has significantly more increase in clinical attachment levels, greater reduction of spirochetes and motile bacteria, better eradication of P. gingivalis. I just have to tell a story here that is not one of my better moments as a hygienist. There's a lot of those stories in my courses. One of the most difficult perio cases I've ever treated was of a man who worked 2 jobs and lived 2 hours away from our practice. I did 1 quadrant at a time because that's what I was taught to do, but due to the distance and difficult schedule, it took me a year to see him 4 times. Needless to say, he didn't get better. The first quad was reinfected before the second quad could be done, and so on. Charles Blair, author of Coding with Confidence, suggests that a narrative be submitted if all the 4 quads are done in 1 day. These reasons in a narrative would include apprehensiveness, medical conditions, extensive travel, pre-medications, or IV sedation. When these things are put into a narrative, you'll get better reimbursement. But I've got to say, in my practice, we never had any trouble getting more than 1 quad in a day reimbursed. My clients haven't either. You might be the exception, I don't know. If you are, include a narrative. Now, I'm not suggesting that you keep the patient in the chair for 4 hours and do 4 quads. Look at the calculus load, and after an honest time and motion study of just pure scaling, could you name that tune in 60 to 90 minutes instead of 4 60-minute appointments? Especially if the patient's pockets aren't too severe and know that they might get by on nitrous or topical anesthetic. Try it and you'll be surprised how many patients you are over-medicating with local anesthesia. Infiltrate an area if needed and work on another few teeth while that area gets numb. It will speed you up tremendously. If it is early perio with only 4 to 5 millimeter pocket depth, general inflammation and bleeding, topical anesthetic is perfect if it's early perio with only 4 to 5 millimeter pocket depth, general inflammation and bleeding. But just light to moderate super and subgingival calculus and very light to moderate bone loss. You can do each quad faster than you think. Pull up my fee spreadsheet on STM and high production. If you do 2 quads an hour, you more than doubled your productivity, making STM the high production appointment it should be for the work that you put into it. Even if the patient has a ridiculous calculus load, try and get it 2 quads done in 90 minutes. So, second and third appointments should be scheduled as soon as possible. Note, in an upcoming class on scheduling, we will talk about blocking out appointment time for STM so that you don't tell your patients they have this raging infection, but then you get to the admin team and they say, oh, I can't fit you in for 8 weeks. That completely kills any sense of urgency that you created. These second and, if needed, third appointments should look like this. You seat the patient, ask them how their home care is doing, offer a blanket, a bite block, explain the isolite that you're going to be using for them, offer nitrous oxide if you didn't prescribe Valium for them, only if needed. Explain topical anesthetic and use it where needed. Then get to work. On the off chance that a patient jumped on a certain surface that I was working on, I would say to them that, ooh, this must be a hot spot. And then I would tell them I was going to put more topical anesthetic on that site and then go work somewhere else while it gets working and then try again. This had a huge success rate. If it didn't work, I went ahead and infiltrated the site with local anesthetic. I did not hurt my patients. Nothing drives dental patients away faster from your dental office or visiting any other dental office than by hurting them. No joke, I was in an office, a hygienist raised their hand during my presentation at this point and said, but don't you want to punish them a little bit by hurting them? No, that's awful. Don't do that. Pain is not a good motivator. No punishment here at the dental office. We're not punishing anybody. Let's make that clear. Okay, at the active periodontal treatment appointment, it's either a 4341 code. I still didn't polish, floss, or do fluoride on the second or third appointments. They still aren't done. So I submit 2 to 4 4341 codes. When you're doing full mouth disinfection, don't think of them strictly as quadrants. Think of them as there are more than 3 teeth with pockets in that quad. Because we are talking about a patient with generalized perio, there's more likely the equivalent of 2 or more quads that need root planing. It's okay if there is only the equivalent of 2 or 3. You don't have to do 4 or nothing. Don't charge patients more than they need. With full mouth disinfection, you are obviously going to clean all the teeth in 1 or both or all 3 visits, even the healthy teeth. You're gonna get paid for it. Don't worry about it. Next, I let them heal for a month and have them back for the 4th supportive periodontal therapy appointment, or 4910 is what I code this one. It's periodontal maintenance. I sit the patient down, review home care, and reprobe. If there are any pockets that are still bleeding and inflamed, I add a Reston or laser laser to my final scaling. Remember, I always included 4 to 5 areas of treatment of arrestant or laser in the treatment plan and financial arrangements just in case I needed them. And the patient was pleasantly surprised if I didn't, and the treatment was less expensive than planned. This is when I polish, floss, and administer fluoride. Then schedule them back for a 3 to 4 month continuing care appointment at really your discretion. Next classes will be on localized perio and gingivitis. If you have any questions on generalized periodontal disease and treatment planning, don't be afraid to email me.